As we'll hear later on today, the population is getting older, heart failure is a disease of the elderly, and we are going to be seeing more and more people with heart failure, which is a progressive chronic condition. And unfortunately, our heart failure patients do have a high mortality rate. 50% of heart failure patients will, on average, die about 5 years after their diagnosis. So, this is a landscape of a typical journey that a heart failure patient takes. On the left, you can see the x-axis. At the top is normal, good health. At the bottom is death. And on the y-axis, we've got a timeline. So there is a point in time when patients are well. They haven't got heart failure, and their quality of life is really, really good. And then what happens is that they're either at risk or they develop heart failure, and they go through that journey of theirs, initially sort of asymptomatic, very community-based. Some of the sort of focus of our work these days is actually trying to identify the patients as early as possible in primary care. There's blood tests we can do. There are primary care interventions such as stopping smoking, managing weight, which you'll hear about later on, diabetes, blood pressure. There's lots of other things we can do in primary care to actually stop patients developing heart failure. We can diagnose it earlier as well, excuse me, and start some medications in primary care before they actually become really unwell. If we diagnose it early, start the appropriate treatments, we can actually reduce or improve the trajectory of the heart failure journey by about 40%. So there's a lot of work that we can do in primary care, and a lot of our focus is on that. Sadly, we're not getting that right. And what happens is that most heart failure patients in the UK are actually diagnosed when they come into hospital with acute heart failure. So that's where that purple line goes in, and that's the first heart failure admission. And the thing about heart failure is that it's a condition where the heart's not working that well. And when they come into hospital with acute heart failure, about 10% of people die during every hospitalization. So my mortality rate is at least 10% of patients who are admitted on my care. And that's just the natural progression of the disease. If you look at the UK National Heart Failure Audit data, people comorbidities, on average they've got about 5 other illnesses when they come into hospital. So it'd be really great if we could diagnose these patients earlier, start the treatment earlier. But when they come into hospital, that's when they meet secondary care, tertiary care people, and we start doing a lot of things for these patients. So we do angiograms on them, we do bypass surgery, we replace the valves, etc., etc. That's when we start doing all the really sort of high risk, high intense stuff. We start them on all the right medications. And we try and rescue that admission and try and get them home. 90% of patients will go home. 10%, as I say, will unfortunately die. But when they do go home, their quality of life and their functional status is much less than it was before they came into hospital. So there's been a step down in their functional status. And then patients go home, they get patched up, we sort of try and keep them at home. But 40% of those patients will come back into hospital with acute heart failure within 12 months of their diagnosis or their initial event. And this revolving door continues. And as the patient goes through his journey, it's a miserable life that they have. And when they're approaching end of life, when their heart really can't take anymore, their admissions to hospital become even more frequent. They start coming into hospital every 3 or 4 months. And every time they come into hospital, they spend about 2 weeks in hospital on average. And I've seen these patients, you see them in clinic when they're just patched up, gone home, they're stabilized, and many patients say to me, it was horrible in hospital. I couldn't sleep, I was constipated, I didn't get up, I didn't know where I was disorientated. And I know that this is just going to be, just buying time. Thank you for everything you've done. But really, if you can't keep me at home and let me die in my own home, I'll be really grateful. And what happens? 2 months later, I'm seeing them in the A&E department again as they come back into hospital. So that's not right. And the last 2 years of a patient's life, when they're going through that end of life phase of their journey, that's the most difficult time for the patients. They're the most vulnerable. And from a health economics perspective, it's actually the most expensive as well. Heart failure in its entirety costs the NHS about 2% of the annual NHS budget. 50% of that is spent in the last 2 years of the patient's life, when they keep coming in and out of hospital, when they start doing things. So it's a really, really expensive condition, but particularly expensive in the last 2 years of the patient's life. So I think there's a lot we can do in primary care to stop this happening in the first place, or reduce the rate of decline. I think we're okay in the middle. I've been sort of, familiar with this, and most of my time is spent, in the middle section of that journey, trying to do as much as I can in the primary care sector. So I was aware of that. But every now and then you come across a patient that makes you stop, think, reflect, and look back and try and make some changes. So I'm going to talk you through one such patient. So this is Super Mario. Okay, so Super Mario was actually an Italian chap. His first name was actually Mario. And every time he came to hospital, every time I saw him in clinic, I used to call him Super Mario. Okay, so he was a 60-year-old. Actually, when I first met him, he was 55. He was a 55-year-old chap, Italian origin. He had lots and lots of cardiac risk factors. He was diabetic, he was an ex-smoker, hypertensive. He enjoyed his life. He was, I think he worked for the railways. And, he had a decent life. He had a really loving family. But in 2007, he came into hospital with acute cardiogenic shock. And I actually still to this day remember exactly which bed he was on in our primary care unit, because this guy was sick as a parrot. He was really, really sick. He was acutely unwell. He was on every inotrope, he was on adrenaline infusions and all sorts of things. We're trying to give him everything to keep his heart working. We put a balloon pump into him. We just about managed to rescue the situation, and got him just well enough to go off and have emergency cardiac surgery. Bypass surgery, microbiome. But the reason I came into hospital was that he had myocardial infarction, acute heart attack. He actually ruptured his microbiome as part of that acute heart attack. So he was really, really going on. And we were lucky, we managed to salvage that. We got him back. Before he went home, his ejection fraction had improved to 40%. So those of you who are not familiar with ejection fraction, a normal ejection fraction of the heart is about 50%. 40% is a marker of moderate weakness of the heart. And he was put on OMT, which is optimized medical therapy. So to rescue the situation, we were really pleased with ourselves. We got him home. And he was well for the next 5 years. He was functioning, he was still at work. We actually managed to get him back to work, and he was doing well. 5 years later, he came back into hospital, and now his heart failure was getting worse. It was more symptomatic. And NYHA is a marker of functional limitation. So the classification goes from 1 when you're extremely well, and to 4 where you're essentially bedbound. This guy was now NYHA class 2 or 3. So we're struggling to go to work. His ejection fraction had dipped down 30%, so now it's more severe heart failure. His ECG showed some changes as well. And so I thought it was time that we put this thing called a biventricular defibrillator into him. So normally this is a defibrillator and a pacemaker. It's normally put in on the left side. Super Mario being Super Mario caused anatomical difficulties. He was actually born with a congenital abnormality, which meant that his circadian veins actually drained. Won't go into the technicalities of it, but it meant that we had to put a right side of the device into him. All the catheters and things are designed to go in from the left side. I'm actually right-handed, so doing left. So anyway, the point I'm trying to make was this was actually a challenging case. It took much longer than it should have taken, but we did that. Okay, and he did well. He was well for another 3 years, and then he came back in again to hospital. This is now 8 years after his initial presentation. Now the grafts that he had, his emergency bypass surgery, were beginning to fail. And so he was in trouble. So he went for redo bypass surgery. Okay, now that's really high risk, really, really high risk. Okay, and now his aortic valve is tightening up as well, so he's an aortic valve replacement on him as well. So this guy has gone through a huge amount of stuff, done loads and loads of stuff to him. Throughout this whole time, we also enrolled him in a lot of our clinical trials that were ongoing. So there's a paradigm study, our device studies. He was on warfarin as well because he had mechanical valves. He was coming to the warfarin clinics regularly as well. So we had lots and lots and lots of visits to hospital and lots and lots of opportunities to engage with us. So over this period, I really got to know this guy really well. Okay, it was a 10-year journey that I've known him. I got to know him really well. I'm a big Cardiff City football club fan. Okay, so Super Mario. This spanned the period when Cardiff City was in the Premier League era. So we kept on talking about, are we going to win it? Are we going to get into the playoffs? These are the conversations we were having in clinic. As I said, he was about 55. He was now 60 plus years at this point. We were talking about his retirement, what he was going to do. I'd seen him grow up with his children. I'd seen him introduce his grandchildren to clinic as well. He was talking about his retirement plans. His big wish was he wanted to go back to Tuscany. He wanted to build himself a little villa and actually have a holiday home for the family all to come and visit. In fact, he kept talking about Tuscany. I actually remember he convinced me to take my annual holiday to Tuscany one year as well. So I got to know him quite well. And this is stuff, a chap that we've done a lot for. About 10 years later, unfortunately, his disease progressed. He was now in OHA class 3, really reduced mobility, spending more and more time in his house now. He wasn't able to enjoy his life with his grandchildren. He was having more frequent hospitalizations, acute heart failure, and as I say, he was spending 2 weeks in hospital. He developed cardiorenal syndrome, so when the heart is really poor, it doesn't perfuse the kidneys very well, and you get into this horrible sort of cardiorenal sort of self-fulfilling badness. But in the end, in the last few weeks of his life, all that has been lost because he actually failed in that at the end. So you go home in the car, you're thinking about this, and you have to try and make some good. So as I say, every now and then, a patient turns up to actually makes a change the way you think about things. So this is where the planet saw a care consultant who started in the hospital. She has an interest in non-cancer care. Okay, so up to now, part of care has all been focused on cancer care. So we met up and we developed some co-speciality and the right pathways. Spread the model and scaled it up. So I'm running out of time, but basically we meet up regularly. We identify the patients who are approaching end of life. So the Super Marios in the sort of 6 months before they die, hopefully we capture them. We then discuss in a multidisciplinary format. On the right of that picture there is the heart failure team. On the left is the palliative care, or we don't call it palliative care, it's actually supportive care team. And we refer our patients across. This is some of the data that we've got showing that actually patients who enter the service, we can reduce their hospital admissions, we can reduce the bed days. The amount of money we're saving is enormous. It's going into millions of pounds. The health board absolutely loves it. But more importantly, the patients and their family really love it. And when you look at the patient feedback, they would recommend the service. They feel it's more coordinated, it's more compassionate, they've got a better understanding of their disease trajectory. They're able to feel their feeling, discuss their feelings and their thoughts of them, improve quality of life, they feel listened to. So in summary, heart failure, very, very common. This is an epidemic waiting to happen. It's got nothing to predict when they're going to die. With heart failure, it's very unpredictable. And we have a pool of very vulnerable patients who don't fit into any specialist services very well. We can do something about it. We can actually make a difference, facilitate end of care life at home. It's highly cost effective and patients really love it. Thank you very much.
This is actually for Professor Yousef. I was thinking between the two lectures, we've been following the assisted building. I'm a consultant physician, so we are sort of aware of how this might sort of come into our environment. And other than the few cancers that
I think the two cancer diagnosis where we can easily give a prognosis of 6 months, it actually worries me. And coming back to you with your heart failure, those last 2 years, where you see your patients, do you see yourself being able to give that 6-month window to your patient? Because as a general physician on the wards, I see them as well. And it's not a right position to be in, is it?
So thank you for that. That's a really, really good question, actually. When we set this model up right at the beginning, that's one of the questions we asked ourselves. So I did a lot of work looking at the literature and stuff. There are some models. So there's the Seattle heart failure questionnaires and there's the prognostic indexes that you can use. Rubbish. Absolutely rubbish. Because we went back and retrospectively looked at the patients who'd actually died and we put their data into the models. Actually, a monkey could have done better. So then what we did was we actually said, well, actually, when we sat down as a group, we said, look, can we, as experts, looking after these patients, predict not which patients are going to die, because that's not the question that we're asking. Can we predict which patients need extra help and support? Okay, the majority of which will probably end up dying. So rather than asking, can I predict when this patient is going to die? I don't think that's the right question. The right question, I think, is, does this patient and the family need more help and support? Okay. And absolutely yes. As the healthcare professionals looking after that patient, if you just change that question a little bit, you can actually identify the patients much better. And then we can refer them or discuss them with our supportive care MDTs. So we've identified what the needs are. Actually, this patient's main problem is he's constipated because of all the heart failure medications we're giving them. They need more help with this. Can you sort of help with that? Or this patient actually got a really dry mouth because we're diuresing him so much. Because we have to diurese him to keep, we can actually have targeted things. We know what the problems are. And then we can actually sort of have a discussion about that and join care to address the problems. And the majority of these patients will die. But the question is not when are they going to die, but actually can we identify the patients who need help?
Thank you.
Yes, just a very, very quick comment. Thank you for your question, because it's really important. When you're looking at the law, we're talking about making a statement with legal certainty. I've looked after thousands of cancer patients over the years. My biggest error was somebody where 4 of us, consultant, surgeon, oncologist, GP, and myself as a consultant, all thought he'd be dead in 3 months. We are now 34 years later, and he is still alive and not living terribly far from here. But in the meantime, his wife died, and he's brought up the children on his own. I've learned that I just can't predict prognosis. I know it would be easier for everyone if I could. We've given patients, they get their DS 1500, they now will get their 1 year, but we know that at 3 years, 20% of those people are still alive. So trying to predict prognosis is nigh on impossible. And the systematic reviews that have been done have demonstrated that as well.
Thank you. Anita, would you like to comment on this question?
I just agree with the uncertainty of prognosis. I look after dementia patients who are not eating and drinking for months, and I'm asked can we fast track them. And it's a really, really difficult call to make, and to realise that the limited resources we have to allocate those to the ones in most need, and potentially with the high need and the shorter prognosis, and that's really a big challenge. So I just agree that predicting prognosis and being put on the spot and being asked to decide where that resource should be allocated is really impossible, and it changes all the time.
Thank you. We have another question.
Yeah. This is for all panelists. How can spiritual, emotional, and cultural needs be better integrated into the end of life care?
I think that it's absolutely spot on. Cicely Saunders described a model of total pain and total distress, where the pain or distress of somebody is vastly increased by spiritual distress, emotional, psychosocial distress. And I've seen it so often. Whoever comes in, whatever religious group you are, chaplaincy services generally, are across all different groups and can be really very, very helpful. Oh, sorry, don't know why that happened. Just to give you an example quickly, we had a woman referred in on 1,000 milligrams of morphine a day with uncontrolled pain. It was the chaplain allowing her to talk and the care assistants who discovered that she'd been abused for many, many years at home. We think that doctors do it. People are scared of talking to us as doctors because we have power. And actually you disclose to somebody who you feel is at an equal level.
Thank you. Jenny Rathbone, would you like to comment?
Yes. I'm a member of the Senate, and we're obviously going to have to vote on this bill. It's something called a legislative consent motion, but clearly there will be lots of implications of this end-of-life bill for the NHS. So many of you work in the health service. For me, it's about extending the right that some people already have to end their own life to people without money and without, if you like, the intellectual capacity. Because a very close friend of mine went to Dignitas over 10 years ago. She was the sort of person, she had lung cancer, and so she lived with it reasonably well for about 5 or 6 years, but she was absolutely the sort of person who wanted to be in complete control all her life. And when she started deteriorating, that's when she decided she wanted to end her own life. And it was only because, A, she had the money to take herself and other members of her family with her to Zurich, and also they, between them, had the intellectual capacity to not reveal why they were making this journey, because otherwise they could have been stopped. So she got the death she wanted, because she had those things. And there are other people, like my friend, who would like that same right to be able to end their life before they are completely dependent on other people for absolutely everything. I know another friend of mine who died very recently, who was a psychiatrist. He didn't want to take that route because he had a better understanding, I suppose, of the physiology of dying, and he had a family who were very resourceful in making it a completely wonderful death at home. But that's all too rare. Many of my constituents have horrendous deaths, either in hospital, a really busy, noisy hospital. Nobody wants to die in hospital, frankly. Some people do. But equally, I've known constituents who had really bad deaths in hospice care. Really awful, awful deaths. And the relatives left behind have been really dogged by that, and it really distressed them through the rest of their lives. So I agree, absolutely, we need to do a lot more to enable people to die in dignity, whether it's at home or whether it's in a hospital if that's necessary. But I think at the end of the day, it's about having the right to die when you want to end it all. And I've completely understood all the things about people who are being persuaded to end their life, and we need all those controls. But personally, I will vote in favour of this bill when it comes before me.
Dr. Pathy, would you like to comment?
I think that you make a good point, and there's a very big impact into the well-being of the patient and that patient's journey. I think that to address that, you need to have time. You need to have time to listen to the patient, and not just for me as a GP, but all the other people involved in the palliative care of that patient. And so you need resources. You need a palliative care team We need time for communication within that palliative care team and all the people involved in that patient's care. And certainly, having moved from urban Cardiff to rural West Wales, the services aren't the same there, and patients are much more isolated and getting a lot less input. And I'm afraid that area is probably addressed less well, and they're probably not having such a good journey. I think if we had excellent services in palliative care across Wales, I think we would probably find a reduced desire for seeking medical death. So what I would like to see is improved access universally throughout Wales for palliative care services, and the time to address those aspects, which I'm afraid are often we medicalise the patient too much and focus too much on pain or constipation and forget to ask anything else about their thoughts.
As a psychiatrist, in terms of making that choice, and for patients making the choice, I would first want to make sure that a holistic assessment is done, especially unmet needs are met. We've just heard the other speakers talk about it as well. Palliative care is extremely important. But as a psychiatrist, I would like to also know that any terminal illness can cause alteration in mental health. So when we see patients with suicidal sort of intent, what we try to do is mitigate the risks. And when somebody is faced with a terminal illness, we need to make sure we mitigate all the other things that are treatable. And that
comfortably and with as much dignity as possible. And I think this is what you were saying, Jenny, as well. I suspect with the assisted dying bill, if it comes through in the end, a lot of people may go for assisted dying but want to keep it in the back pocket. They want to have it there just in case, rather than I'm definitely going to die this way. And I've got both personal and professional experience of this. My father died in 2012 of pulmonary fibrosis. So his lungs essentially slowly packed up, and he did ask me about 3 or 4 weeks before he died if I would take him to Switzerland, and of course I couldn't, and we didn't. But in fact, he died with dignity at home with his family there, in a way that I would quite like to die too when my time comes, and not in too much distress either. And that was because there was a really good wraparound district nursing service, as well as a palliative care service, as well as a respiratory service that made sure he had the oxygen that he needed.
So just one thing to say in response to Glenna's question, we are the same vintage. When I qualified, when I was at medical school, the average heart failure patient used to come into hospital. When you look at the clinical trials, if a patient came into hospital with acute heart failure, their chance of living more than 6 months was 50%. Okay, so 6-month mortality was 50%. Fast forward 30, 40 years, now these patients' mortality or survival is 50% at 5 years. So there's been a massive improvement in the medical care of these patients. And what that has done is that what we're doing is we're actually now creating a problem of elderly patients with multiple comorbidities, with increasing healthcare requirements, increased frailty, increased fragility, and what we haven't kept up with is all the other stuff, all the sort of spiritual support, community support, palliative care support. And so we've actually created this monster in a way, and we haven't kept up with what we should be doing for the end stages of the game.
Thank you. And we have a last question.
Thank you. I'm Giri Shankar, Director for Health Protection and Public Health Wales. I saw the two talks quite contrasting in terms of perspectives. While we see the end of life, the need to improve palliative care through the lens of a cardiologist, you could see the same end of life through all the other specialties as well. And then from what you described, Laura, where there are so many gaps in the way the bill is presented, and that needs addressing as well. So if you are looking at making a decision, I don't think it's a binary decision between providing an excellent palliative care will negate the need to have an assisted dying bill, or an assisted dying bill is not a sticking plaster or a fix for gaps in palliative care. I think as a society, it's about choice, about how we have, like a choice in everything else, where you don't disinvest in one at the expense of investing somewhere else. So I do see that there is an argument for us, and undoubtedly, palliative care improvement has to happen because the needs of patients, communities are quite different, and it's only going to get bigger and perhaps more complex. So I'd like to ask again, going back to Jenny, you made your point very clear that you will vote for this bill. But I'd like to understand from a Lord's Select Committee perspective, what are the things that you would like to see which would give you the assurance that this is something good to go forward for societal good?
Okay, thank you. I think you have to separate out the principle of whether something like that is going to be helpful in society, and are we going to change the law to help a small number of people, but are we in the process going to jeopardise the care of many other people? And that's the difficult balance in legislation. If you want choice, you've got to have true choice. So if you're going to have choice between whether somebody gives you lethal drugs or something else, you've got to have the other choice there. You've got to have the palliative care services there. Until we get them there, I would say, hang on, don't go and change the law. I'm afraid everybody has the right to die, to end their own life. What this bill would do is give you the right to ask somebody else to bring about your death. That is quite different. That is involving somebody else in shortening your life. And when you look at the stress on the NHS at the moment, it's been clear in the evidence we've taken. How do you manage this in our hospitals where you have patients on trolleys, you have 4-bedded bays? Can you do this behind the screens with the curtains drawn? If you're going to have a side room, who do you move out of the side room in order to give the patient lethal drugs? If it's going to be at home, if you look at the Australian experience, you talk about time, Damien. It seems that each case takes about 60 hours of clinical time. At the moment, we don't have any time at all for our patients. So we really do need to improve our healthcare delivery. The York system is great, it works really well, and is turning things round. And there are, of course, there are always people who feel they'd like to have it in their back pocket. I think people would like to know that when they're in distress at home, they can phone for help and somebody will come out. And what the Super Mario story illustrated is at the moment, even here in Cardiff, with the better resources than elsewhere, we are failing people. And I don't think the answer to failing people is to say, well, don't worry, we'll arrange so you can have lethal drugs instead, and not correct all those problems that we have in healthcare. And it will cost money, and where is the budget coming from? Firstly for training, and secondly for implementation and monitoring. And if we don't implement and monitor and data collect, then we will never discover failures, we will never be able to improve. So, I would say really strongly, I would love there to be specialist palliative care. We were streaks ahead some years ago in Wales, and we just have not developed further, and we've slipped back and back and back. And I think that's really
No, I don't think so. I wanted to explore why is it not possible for this bill to designate the right to die, but not to load it onto the NHS, because it seems we have excellent hospices. They're not perfect, but Home Towers is a great place to die, with the wonderful views across the bay. Why is it not possible for us to have places like Dignitas, if we so choose, that we can go to complete our life? Equally though, I think most people would prefer to be able to get some pills at home, you know, and then do it for themselves. I think that the problem of having the NHS and the corridor care that Alora's describing is, I think, fantastically difficult to see how we could ever make that work, and I don't think that's the way it's going to be feasible.
Neurology and other topics which are common, and we have got more experts in our panel or in here who can cover all of those. So the difference comes when it's a male health issue. And the other thing was that when we were doing a lot of research, which I'm quite involved in terms of the outcomes for, say, prosthetic diseases or kidney stones, we realized that actually a lot of the men's health issues are quite tied up with the family circumstances, and a lot of the decision making, the impact is based on what their partners. There's some research looking at the differences. So when you look at the attitudes to health, when you look at the men's attitude when compared with women, health is often socially constructed as a feminine concern. So men are less bothered about it in that sense. They always tend to play down their symptoms, and there is evidence that potentially serious symptoms might be considered as simply growing old in men. There is also risk-taking behavior, and that is associated with. There is a study from King's Fund which looked at smoking, drinking, diet, and exercise, and linking that with combination of risky behaviors. Men are more likely to demonstrate that risk. So when people have looked at health literacy and how men use the services, there is a lower level of health literacy, and it almost comes to half that of women. Men are less likely than women to use a general practice or visit a pharmacy or acknowledge illness or to seek help when it's required. So there is an example from the London area when people were analyzed regarding coronary heart disease. Those with low health literacy were more likely to be male, non-white ethnic group, and live in a more deprived area with lower levels of education or dysfunction. So men will visit the pharmacy quite less as compared with women. Similarly, when you look at the service use, the general practice consultation rates for men is much lower, especially in a younger age population. And men delay seeking help much longer than women, so they take longer to seek help. This is especially true when you look at bladder and other urological cancers. Men are also likely to, compared with women, participate less in the national screening programs, especially.
Thank you very much for a very insightful talk, Professor Zaheer. I just wanted to bring something. I completed my PhD in male infertility at the Welsh National School of Medicine in the 80s. And I was probably the first woman to research in this field in Wales. Okay. And I realized that during my studies, I realized men had limited understanding about their anatomy and their reproductive organs. And I'm afraid this remains to be more marked in men from ethnic minority background. Now, so my question to you is, what can we do to improve their education as well as the outreach for men? How can we improve their education, or how can we offer better education to men to understand about their body, especially the male reproductive parts?
Okay, I mean, I feel like this is a much wider issue in terms of how this can be addressed. I think with the changing education, a lot of this is nowadays covered in school education in terms of their information on sex education. So one would expect that that would be covered in there. And of course, nowadays in this age, who comes from Middle East, a young boy, 22, and he had a condition called varicocele. And the moment he knew that he has got a varicocele, he wanted me to operate. And I said, why do you want to operate? And he said, no, I'm from a particular faith. In our society, it is so important that I can conceive as soon as I can. And anything that would risk that ability, I would not want to have that. And I said, it's not necessary. You haven't even tried to have a family yet. Why do you think that you are infertile and you want an operation, which itself can carry side effects? So when I had to sit down with him, spend half an hour, which I didn't have time for, and explain that it's not necessary to operate. It's clear that there are certain aspects that need to be addressed in a wider society, as you have mentioned. So strategy may be from public health aspect in terms of focus, attention to teaching or explanation of those things, social media campaigns, all of that can be used for that.
Let me just explain myself. I'm a nurse, but I'm also a clinical practitioner. I'm going to do something very embarrassing. My PhD is in clinical management of premature ejaculation. So I think it's one of the only PhDs in the country with that. So ask me anything. It's a great question, and I've been fascinated. I've got sort of 25 years clinical experience with managing erectile dysfunction and premature ejaculation, most of it in London. And you're absolutely right. Men are not taught about their anatomical bits, and there are tremendous, in my research experience, tremendous variations across different ethnicities. So my Black and Afro-Caribbean patients just don't talk about what goes on below the level of their belt, and everybody colludes with that. So I think part of the problem in this is like normalising how we discuss bits and pieces. And as my colleagues just pointed out, primary schools, they're supposed to do this better. In the Netherlands, they have a much more sophisticated sexual health program at 5 years and upwards. We rely on our primary school teachers to talk about some really uncomfortable subject areas, which doesn't actually happen. So we do need to kind of destigmatise all of this. And one of the programs of research I did was around trying to raise the awareness of how common erectile dysfunction is. Okay, so I won't go into lots of boring details, but the female partners were really very keen to know how they supported their, in this case, their male partners, because it has a tremendous effect on their relationships and their family stability, etc. So these aren't difficult groups to get into, actually. You just have to go along to different communities and say, we think this is a problem, what do you think? And then, well, how can we get this message across? And my experience has been, it's fascinating, they will tell you the answer to that. So it is media campaigns, it is destigmatising, but it's also, my wife gets me to do things, so no stereotypes here. So that kind of pressure from the environment, from the family, to go and get things checked out, I think is really, really effective as well. Does that answer your question?
Yeah. Dr. Zaheer?
Just yesterday we had some friends over, both quite eminent doctors, and they said, oh, what panel are you on tomorrow? And I said, men's health. And quite interestingly, they responded, men's health? Is that also a thing? And it is, but it is largely ignored, and it's largely
different sort of viewpoint. The first is just a reflection, because this is sort of my third weekend in a row that I've done a public engagement event. And what's really interesting was that the first two events, I mean, the second one was the Women's Association, one, a couple of colleagues who were there last week are there here as well. But the first one as well, there are very few men who normally engage with healthcare, and there was always a majority that there are more women turning up for these events and taking interest, etc. So I think there's a general trend and narrative, and I think the evidence also shows that men tend to put off healthcare concerns. So I think that's one point that is borne out in life, and part of all our roles is to improve education, which brings up to my second point, because I mainly, most of half my work is dealing with memory and Parkinson's, that group. And one of the things we focus a huge deal on is about preventing or reducing the risk of dementia or delaying it. And there's a very interesting concept about the reversible concepts around dementia and what everyone in the audience and us can all do to prevent or reduce this risk. And that brings me to one of the things that Scotland has done very well. It's taking that information, and over here, for example, about men's health, to where men congregate. So, for example, if there's a big rugby event happening in a stadium whose name I shall not take for various reasons, they would have leaflets about this in those areas, going to where people congregate, people of faith, especially, for example, if ethnic minorities, whether the churches or the mosques or the temples. And we did a piece of work in Cardiff and Vale, and there is similarities here between prostate health, for example, men's health, and the work we've done. So we just looked at what is happening to the referrals that are coming into memory clinic, for example. So we get approximately 2,500 referrals a year.
Health was mentioned a couple of times. I thought I ought to respond. And then I have a question to ask as well. The first thing is, it was quite contrasting to hear that there was one panel member whose view was that social media is helpful, and another panel member who says social media is not helpful. But I think because the theme of today's conference is inequalities, we need to just focus on what gap are we trying to address. Is it a knowledge gap, it's an attitude gap, or is it a practice gap, or a combination of all three things? From a public health science point of view, we are interested in bringing about behavior change in men. And we have to empower everybody to make that behavior change. And one of the tried and tested models to bring about behavior change, which we often refer to, is called the COM-B model, C-O-M-B. C stands for capacity, so you should have the knowledge gap. O is the opportunity, that you should just having a knowledge won't be sufficient. You must have create that opportunity. And the most important bit is the M, which stands for motivation, which is where I think the men's health is quite weak in terms of when that all three things align: capacity, opportunity, motivation, it brings about behavior change. And that is whether it is about screening programs or inequalities, etc. So within Public Health Wales, we have a behavior change unit, and we are very interested to engage with the wider diverse community and train key clinicians like yourselves who see patients every single day to be able to deliver parts of that COM-B model to your patients so that they can bring about some behavior change. So that was just a response. My question was, given that we are looking at men's health in a not in isolation, but in a continuum of all the health. And given we are in the ethnic minority women's Welsh healthcare, what do we see as the role of women who are in healthcare in promoting men's health?
Thank you. Who would like to answer first?
Shankar, you probably got trained by Roald Dahl. That's a twist in the tale, isn't it? Or googly. It's very complementary and supplementary, isn't it? It's I think it's really important for women to support men's health, because the natural tendency for the man will be to try to man up. But there are other things which is part of the problem. When I knew I was going to speak on this men's health thing, I looked at my last couple of months of lists. And certainly every morning, 18 patients. I had a ratio of 7:3, so 7 women for 3 men. And if I then took out the reproductive ages, which you'd expect women to have significantly more issues, it still was 5:3. And we know that Public Health Wales figures are that men are 34% less likely to present with the same problems than women. So I think encouragement as much as possible and engagement with men, which has to come from all of us. I mean, all of us are men here talking about men's health. It would be nice to have a woman there, so that's interesting. The other thing is an acceptance, I think, that irrespective of education, environment and everything else, men and women are wired differently. I never have any hesitation in talking about my own health because I do use it as an example when I'm talking to my patients. Men complete suicide significantly more than women do, who attempt suicide more than men. So I'll give you my example. I didn't try. I suffer from chronic pain, having broken my neck and having various back issues.
Joshi said, men generally are much less aware of their health conditions or why they take what medication they take. I have to take a medical history every time I see a patient, and I usually have to ask the question in at least 4 different ways to elicit all the information that I need. Men are very bad at knowing what their medication is for, what medication they're taking. And we nowadays, as I'm sure you all do, try and concentrate on the whole person rather than just their mouth. So we look at things holistically. We explain to patients the connection between their oral health and other general health conditions. So although I'm not suggesting that prostate cancer or prostate conditions is linked with general health necessarily or oral health, I do have an opportunity to speak to people. Once they're sat in my chair, I have a captive audience. And because of our personal family history, I take that opportunity whenever I can to speak to people who I think it may be relevant to. So I speak to my older male patients about their general health. If I can see from their medication that there is anything connected with prostate cancer or enlarged prostate, you might think this is none of my business, but I'm in healthcare, so why not? I think we all have to try and think that way a little bit. Where there is personal influence, personal experience that expresses that, if we have an opportunity, just open it up. Men have no idea why I'm talking to them about this, but there's this psychology of having someone laying back in a chair too, that I won't go into in any great detail, but you can probably imagine sometimes a chap will open up a little bit more, even though he's a woman and even though I'm looking at his teeth, just because that situation is a little bit different. And again, that echoes what someone else said earlier. I'm not the dentist. I'm the hygienist. I'm not the highest of the echelon, so they can open up a little bit more to someone like me. Thank you.
Thank you very much. And I think on that note, we will end this session. And I'd like to thank our speaker and the panelists very much for a very stimulating talk and discussion. You know? And what an amazing conference and excellent speakers. Thank you so much for being here today. It's been a fantastic event. My special thanks to speakers and panelists and everyone in this room. A big thank you to our volunteers. Your support is much appreciated. It wouldn't have been possible without your help. So a big round of applause for us. I also thank Claire from Same and Different for sharing their powerful exhibition, Dying to be Heard with us. Over the course of this conference, we have confronted some of the most pressing. And as we now close, I invite us to reflect not just what we heard, but on what we must do. I was going to give you a summary of this conference, and I think I can't really understand my own notes actually, so it will take me some time to go through them. But I promise you, I have to write this summary for the Royal College of Pathologists Bulletin, and when I've done that, I will share it with all of you. Okay, across all the 3 themes, one truth stands out, is that health inequality is not inevitable. It is shaped by policy, culture, and systems, and it can be changed. And that's what we aim to do. I hope The insights shared today will help in drafting action points in boardrooms, clinics, classrooms, and communities. Parvati Women in Welsh Healthcare is a voluntary organization, and we are currently looking for mentors and mentees for our mentoring program. So if anybody is interested, please do get in touch with me. You will definitely benefit being a member of this program. Thank you once again for your presence. Let's carry the momentum forward and make equity not just a goal but a legacy. And the dinner will be served at 7 o'clock downstairs. So I look forward to continuing with our discussion there. And we are going to have some Bollywood entertainment followed by after dinner speech. So I hope you will have a good time during dinner as well. Thank you so much.